So good afternoon, everyone. I'm Jamar Barati from Memorial Sloan Kettering Cancer Center, New York. I'm excited to start this very interesting session. We have excellent speakers. I think there are from the past, the present, and the future of liver surgery and minimal invasive liver surgery. We have a pretty tight schedule, and I'm looking forward for the discussion session. So please make sure that you write down your questions in the chat box, and we will later discuss it. Co-moderating with me will be Dr. Javier Briceño from Spain. So Javier, why don't you introduce yourself and get started with the first speaker.
Hi, I'm Javier Briceño. It's a pleasure for me to be here, and thanks, Dave, for your fantastic congress. Our first speaker is Nicholas O'Rourke from Australia, who is going to talk about history of liver surgery. Thank you.
Hello, and welcome from Australia. I hope everything's going well in New York City. I wish I was there with you. I've been asked to talk about the history of laparoscopic liver surgery, and that's what I'm going to do. There are multiple pioneers. These are just a few. Sandia Zagra blew me away in 1992, I think, when I saw him doing a left lateral sectionectomy video. Hiro Kaneko was pushing the envelope in Japan, and Cristiano Huscia was doing big things out of Italy. In fact, it was in a meeting in 1996 at Sages in Philadelphia when I saw Cristiano perform a laparoscopic right hepatectomy with a big video. It was in a big room. You can see Michel Gagnon down the bottom. He's another pioneer. He was there as well. And literally, I was very impressed. So impressed that at the end of the video, I stood up and started a standing ovation, and a few people around me stood up. And when I was relating this story, telling my friends about this, Horatio Asbun claims that he started the standing ovation at the same time. But both of us were very impressed, and both of us went back inspired to do more laparoscopic liver surgery. Back in Brisbane, inspired by what I'd seen in Philadelphia, I started doing more lap minors, did a left lateral in 97, and then did a lap right in 1999. Here's my very first patient underneath the liver, having divided the right hepatic vein with a stapler. So this was back in the end of the last century, and I helped organise this meeting, the IHPBA in Brisbane in 2000. But of course, this was the early days of laparoscopic liver surgery, and so not surprisingly, at this lap liver meeting, there was not one invited talk on lap liver at this big liver meeting. Things changed, of course, and I loved going back and forth to Miami over the next few years, as did other friends from Europe, and we spread the word, and the Americans came on board, and Horacio was there, and eventually, enough of us got together, and led by the ebullient Joe Buell, and organised a meeting was formed. And 70 liver surgeons flew in from around the world, and Joe was very clever. He organised not just laparoscopic enthusiasts, but also laparoscopic naysayers, open surgeons who came and listened, and some were persuaded and some not. But it ended up with a publication, a highly cited publication, of course, on the international position of laparoscopic liver surgery. Dave Geller was one of those enthusiasts, and he reported this again highly cited paper where he looked at the number of laparoscopic liver resections, and you can see really there was almost nothing in the last century. It really just took off from the year 2000 slowly on and crept up, and it's gone more and more ever since then, of course. In fact, since that day of that time of 1,000, there's well over 10,000 been reported now by my friends Daniel and Go and Ruben Syria. Go decided there should be another meeting, and he was quite right. It was a great meeting. This was in Morioka, Japan in 2014. another consensus conference, and this led to another consensus statement. And the interesting thing was we'd all talked about laparoscopic liver resection, and although Daniel Shirky had dabbled with pediatric liver transplantation laparoscopically, the big news, one of the big news stories here was the beginning of laparoscopic living donation. So my friend David Kwan presented his first 20 cases of totally laparoscopic living donor. And this people were obviously very impressed by this. And it's taken off, as you may know, mostly by my friends in Korea, but also Alan Coffrin did some lap assisted. Daniel's continued to push it, as has Olivia Subran, and my friend Ho Sung Han has also done a lot. So after this meeting, we kept meeting at the IHPBA or the various regional HPB meetings around the world. And Daniel floated the idea of possibly our own organisation. And this was in 2015 when we all met up in Singapore. And we just wasn't sure there was the alcohol talking, but we all decided, yeah, why not? Sounds like a good idea. We'd all had fun at all these meetings. We'd all learnt a lot, and we'd all enjoyed the friendship and the camaraderie from what ensued. So we decided to form the ILLS, an International Liver Society. And so we got together, and this was the inaugural meeting, again, linked into the IHPBA in Sao Paulo in Brazil in 2016. And it was, you can see, a lot of enthusiasts in the room. We had an executive council, President Daniel, and Go Wakabayashi was president-elect. Secretary General is my title, but it was nothing like Boutros Ghali. I realised I had no power, as in most of my life. Joke, joke. There were 16 large members, as Daniel liked to call them, and these were we were trying to include people from all around the world, enthusiasts, of course, in laparoscopic liver surgery, and these numbers have increased. The first meeting was in 2017, where we had over 200 delegates. This was a great success and cleverly run by Daniel, so it was no cost to the society, and it truly was a great inaugural meeting. There was lots of socializing. It was the beauty of a one-room meeting where there was no parallel meetings. Everyone was focused on the same topic, and there really was some wonderful videos, wonderful presentations, a lot of data presented, and it really was the beginning of a great beginning to the organisation. And I think one of the most impressive things was all the free papers that were presented, and the winner of the best video was a delightful video on various sectionectomies from Vietnam, and it was an indication of how truly international the organisation had become, even in its infancy. In 2019, there were over 400 delegates made it to Tokyo for the next meeting. And this, once again, was a very successful meeting. And I can't really, Minoru and Go did a great job, and we all learnt a lot. And even better for the organisation, we made a significant profit. Probably more than we're going to make this year, but we shall see. There were lots of young surgeons, which is always encouraging to me, being part of the old guard now, but I was delighted to see youngsters like Ronald Van Dam and Sean Cleary there and presenting, and a few of my three boys at the top, as you can see, at the Cremaster bar, which was quite a popular bar. I'm not sure why. So ILLS has gone from strength to strength. It's been very successful. There's been enthusiasts in various countries that pushed it in different directions, but we have registries which have been set up, very successful registries, particularly in Japan and Italy. The collaborations keep coming, and it's really been a great organisation to be part of. As you know, this is where we'd all like to be, and I'm sure some people are there, but it'd be great if we could get there. Such a shame with COVID that we can't be all together enjoying the social aspects and the camaraderie. And I think you'll all agree, you do learn more from a meeting in the flesh than sitting in front of your computer. Let's hope that in 2 years' time, we will all be able to meet in Rome. I look forward to this meeting with Mo, Luca and Roberto. Hoping, I'm sure, that there's no COVID. I think that it's going to be truly demonstrative of the progress that laparoscopic liver surgery has made in the last 20 years. We've gone from simply doing fairly basic but even major resections to complex precision surgery, and I'm sure the videos and the demonstrations that you'll see in New York will be improved on even further, if that's possible, in Rome in 2023, when I hope to see you all in the flesh. All the best, and I wish you all very well and a healthy 2021.
Thomas Earl Starzl is widely considered the father of modern organ transplantation. Starzl was born in Lamars, Iowa in 1926. He lived in the same house for 17 years. Young Tommy worked at the local newspaper that his father owned. He joined the Boy Scouts and had success in high school sports, playing tight end on the football team and wore number 10 jersey for the Bulldogs basketball team. Starzl served a year in the U.S. Navy at the end of World War II. He graduated from Westminster College and got his MD PhD from Northwestern University in 1952. He completed his surgical residency at Johns Hopkins and the University of Miami. He returned to Northwestern as junior faculty in 1958 and was awarded a Markle Scholar. He moved to the University of Colorado in 1961 and to the University of Pittsburgh in 1981. He retired from clinical transplant surgery in 1991 and remained active in transplant research until the time of his death. In 1963 in Denver, Colorado, Starzl performed the world's first liver transplant on a 3-year-old boy with biliary atresia. Upon release of the clamps, the liver immediately assumed a good color, and despite the hectic circumstances of the transplant, it was initially thought that a good result would be obtained. However, after about 15 or 20 minutes, it was noticed that all raw surfaces were profusely bleeding. A sample was sent down to Dr. Kurt von Kaula, and the report came back that there were extremely high titers of fibrinolysin and low titers of fibrinogen in the submitted blood. The next 5 or 6 hours were spent in a desperate effort to control hemorrhage, using literally thousands of sutures and ties, but the hemorrhagic diathesis could never satisfactorily controlled. The child had a cardiac arrest at about 6 p.m., which was successfully reverted with cardiac massage, and during the ensuing 2 to 3 hours, several more arrests occurred. Finally, at approximately 8 p.m., with the advent of the final cardiac arrest, the child was pronounced dead. Thomas E. Starzl, MD. Starzl performed 4 more liver transplants that year, but all recipients died within 3 weeks. There were also failed attempts by Franny Moore in Boston and De Merlo in Paris. All liver transplant activity ceased until the summer of 1967, when Julie Rodriguez became the first liver transplant recipient to survive greater than a year. Here she is sitting on the lap of visiting transplant surgeon Carl Groth. After Julie died, the Swedish artist Dietrich Grunwald painted this memorial tribute to her, picking daisies, and this painting remains on the wall in Starzl's home in Pittsburgh. In 1970 in Denver, Starzl performed a liver transplant on a 4-year-old girl with biliary atresia and an incidental 3-centimeter hepatocellular carcinoma. She remains alive 50 years later and is the longest liver transplant survivor. In 1980, Starzl decided it was time to leave Denver. Here, he's sitting on Malibu Beach with his loyal assistant Shanu Atsuki when they were visiting UCLA. Ultimately, he decided to come to the University of Pittsburgh, where he was recruited by Dr. Hank Bonson, chairman of the Department of Surgery. Bonson was familiar with Starzl from their days together at Johns Hopkins. Here they are skateboarding in the parking lot of the hospital in 1983 between OR cases, and here you can see Dr. Starzl enjoying a baseball game with his wife Joy at Three Rivers Stadium. The liver surgery service formally started at the University of Pittsburgh in 1981 after Starzl's arrival. His tremendous impact on the city was demonstrated when Pittsburgh Magazine named him Pittsburgher of the Year for blazing new trails. Amongst many transplant milestones, Starzl performed the world's first liver transplant in Denver, Colorado in 1963, and the first successful liver transplant in 1967. In 1984, he performed the first heart-liver transplant on 6-year-old Stormy Jones in Pittsburgh, and she went on to live to be a teenager. For 3 decades, from the 60s to the 90s, he had countless immunosuppression breakthroughs and landmark chimera and tolerance studies. Starzl's legacy were the patients he operated on, the surgeons he trained, and the science that he advanced. Iwatsuki, Todo, Tazakis, Fung, and Marasi were a handful of surgeons that spent more than a decade with Starzl and then moved the field forward on their own right. From more than 2,300 publications, I've highlighted a few of the most noteworthy papers. Homotransplantation of the liver in humans, SGNO 1963. Single center experience with primary orthotopic liver transplantation with FK506 immunosuppression, Annals of Surgery 1994. Antigen localization and migration in immunity and tolerance, New England Journal of Medicine 1998. Tolerogenic immunosuppression for organ transplantation, Lancet 2003. Immunosuppressive therapy and tolerance of organ allografts, New England Journal of Medicine 2008. Documenting his influence in the field, from the top 25 most cited publications in the early liver transplantation literature, Dr. Starzl was first author on more than half of them and co-author on 70% of the papers. From that courageous day in 1963, more than 184,000 liver transplants have been performed in the USA. Last year in 2020, 9,000 liver transplants were done in the United States. In addition to transplants, Dr. Starzl also pioneered complex hepatic resections for cancer, hepatic trisegmentectomy and other liver resections, SGNO 1975, right trisegmentectomy, SGNO 1980, left trisegmentectomy, SGNO 1982, experience with 150 liver resections, Annals of Surgery 1983, hepatic resection versus transplantation for hepatocellular carcinoma, Annals of Surgery 1991. Starzl and his wife Joy loved dogs. At one time they had more than half a dozen in their home. The dogs would sit around the office while Dr. Starzl would write his papers by hand with a fountain pen. His autobiography, The Puzzle People, is ranked one of the top 5 books about physicians. For more than 220 honors and awards, Starzl received the Medawar Prize in 1992, the Presidential Medal of Science by George Bush in 2005, and the Lasker Award for Clinical Science in 2012. In 2016, Dr. Starzl celebrated his 90th birthday at Heinz Field, home of the Pittsburgh Steelers. It was a reunion of more than 300 transplant surgeon trainees, all coming to pay their respects to Dr. Starzl. Dr. Starzl died peacefully in his sleep a week shy of his 91st birthday. I took this photo of the Navy Honor Guard folding and presenting the flag to Joy during his funeral. Due to his great contributions to medicine, the University of Pittsburgh commissioned sculptor Susan Wagner to produce a full-size bronze statue of Dr. Starzl. Here she is in her workshop with her blowtorch putting on the finishing touches. The sculpture sits on the lawn next to our Cathedral of Learning, and here's Joy sitting with Dr. Starzl during the formal unveiling. In summary, Dr. Starzl was a pioneer in organ transplantation. As a surgeon scientist, he made tremendous advances in immunosuppression, organ preservation, tissue matching, liver regeneration, chimerism, and innovative transplant techniques. Importantly, he was a mentor to hundreds of surgeons. Prior to his death, a documentary called The Burden of Genius was made about Dr. Starzl's life, and I highly recommend it if you haven't seen it. Thank you.
Thank you so much for the kind introduction and for the invitation to speak today about benchmarking for perihilar cholangiocarcinoma. This is a disease that is well known from this audience, from the perihilar area in the liver, which require a major liver resection in order to achieve a R0 resection. It is also well known or well established this is a very high risk procedures with a high morbidity or even mortality. Now, if we take these three cases, for example, from surgery for perihilar cholangiocarcinoma, we can see that they follow a very different course, and outcome could be the same for centers or also for techniques. So we have here a different modality with different outcome, and how can we interpret those results, and it comes to the concept of benchmarking. So the concept of benchmarking, which now has been used for a number of procedures, follow a circle in order to achieve the benchmark value or the cutoff, what we need to achieve. So the first step is to identify the best possible centers. And here the surrogate marker are high volume centers. We took centers worldwide. The definition of high volume was more than 10 surgery for perihilar cholangiocarcinoma per year, and we wanted to cover a recent time for 14 to 2018. That's the centers that we could recruit. You can see large number in Asia, particularly in Japan, but not only in Europe, and 3 centers in the United States covering the 3 different continents. The next step is to take the ideal patient for major liver resection with perihilar cholangiocarcinoma. That means the low-risk patients. So here we will take those with no distant metastasis, no vascular invasion requiring reconstruction of the artery, no liver transplant or combined procedure such as Whipple procedure, and very importantly, we eliminate all patients with significant comorbidity, particularly cardiac or pulmonary problems. From those, we identify almost 2,000 cases of perihilar cholangiocarcinoma. 700 of those were ideal or so-called benchmark cases. We go further in our circle to identify a benchmarking, and then we need to establish the benchmark. What do we want to know? And how we do it. So I give here an example of different institutions around the world. Here would be the value. It could be, for example, CCI or morbidity or mortality. Here are the box for the different values. And what we're interested as a benchmark is the 75 percentile, not the median, but the 75 percentile to give some room in the best result that we can achieve. I go for time directly to the results of those perihilar cholangiocarcinoma centers. We had in total 21 benchmark values. For example, the duration of surgery, less than 8 hours, blood loss, less than 1.1 liters, time in the intensive care unit, less than 2 days, or in the hospital, less than 19 days. In terms of complication, we can see that most patients had some complications, CCI relatively high, less than 30, bile-leak in almost 50% of the cases for the benchmark value, and liver failure should be less than 35%. So this concludes of a very high morbidity of surgery for perihilar cholangiocarcinoma. And here, the reality with mortality in hospital, 8%, and the 3 months mortality, that's the time we look for major liver resection for previous study, less than 13%. 13% mortality as the benchmark cutoff for this surgery. How this compare with other procedures? We did studies in living donors, in liver transplant, Whipple operation, or even ILLS, looking at some benchmark values. And here's the perihilar cholangiocarcinoma, and you can see we are at the highest of the different cutoff. 90% for any complication, 70% for serious complication. The CCI 30, while for liver transplant is the same, less for the other procedures, and a mortality of 13%, which is much higher than the mortality cutoff associated to any other procedure. Even liver transplant was at less than 2% for these benchmark cases, 4% for ALLS, and perihilar in the center is 13%. Now, if we go further in the circle of benchmarking, we need to analyze the gap between different group or higher risk, and that's what we did in the same series of patients, the same centers. This is the benchmark value that we just mentioned, for example, in-hospital mortality of 8%, and then we took a higher group, people who have a high BMI, so more than 35, cardiovascular disease, or have a ASA more than 3, and we can indeed here see the gap. There is a gap compared to the ideal or the so-called benchmark cases. For example, if we look at the CCI, much higher, 43, and the in-hospital mortality moved from 8%, which is already pretty high in benchmark cases, to 17%, and the one-year survival dropped from 77 to 64% if we take this higher risk of patients. Now, is age a factor? And interestingly, that's what we can identify with benchmark methodology. The age did not play a role. So if this is only the age, no other risk factors compared to the benchmark cases, they are all within the benchmark cases, demonstrating that age per se is not a risk factor for higher problems following perihilar cholangiocarcinoma. Now, I would just put your attention on this slide, which highlight the 24 centers here. What we have in black is the benchmark cases, and in gray, the non-benchmark cases. And very interesting, and here's the percent of benchmark cases. So I have to illustrate what I would like to communicate now. We have center with basically the same volume, about 100, a bit less than 100, but this center has 17% benchmark cases, meaning they operate mostly on high-risk patients, whether it's BMI, cardiovascular disease, but they have a majority patient higher risk, while this center operate mostly, or most exclusively, 80% on benchmark cases. So very different population of patients that you will not be able to see in other methodology, for example, in multivariate analysis. What's the difference? We observed that this center operating on major cases had only 1% mortality in benchmark cases, while the other one was 10 times more. So in other words, more difficult case you do, better is the outcome with the benchmark cases, demonstrating that experience of the centers has a very significant impact on the outcome experience on difficult cases. So the proportion of benchmark cases influences outcome. We observe this with pancreas, with ALLS, liver transplant, any benchmark study done indicated as a new markers that if you operate on difficult cases, your center will perform better. I like to show this small slide here that we published recently on try to illustrate the impact of volume of case based on outcome. And here what we can see, we have the learning curve that is minimum number until you reach a plateau. Here, for example, 60 cases. And what we have also later on, the increasing number is not always a good thing. What we can see is this breakdown point, that at some point the data, the result, come less than optimal on the plateau. And this is due to many other factors that I have no time here to discuss. But one is certainly the structure of the process that is not sufficient for too high volume of cases. So we have volume as a factor and the proportion of benchmark cases. Now, another question that we were asking, since not many expert centers in HPB surgery don't have high volume of perihilar cholangiocarcinoma. So this is the 24 center in which we build the benchmark value for perihilar, but we identify 6 other centers. We are high volume expert HPB center like Toronto, King's College, or us in Zurich. but do not reach the numbers. And here, again, for time, we found no difference between high and low volume HPB centers, suggesting that if you have experience in major other HPB surgery, you may perform as well as benchmark centers when you operate on perihilar cholangiocarcinoma. So the hot topic are, in summary, for a reason we found, which was already identified by others, that Asians do much better in the surgery Asian centers that do the non-Asian center, and this is not related to patient selection, risk factor, but some sort of technical approach, including the modulation of the future liver remnant, not due to obesity as been suggested in the past. We also identified that the results for left are better than right hepatectomy. That has triggered now some discussion and other research. This is relatively new, but outcome is better for left hepatectomy without oncological difference, but the survival and mortality is better. There has been suggestion by the few centers led by Peter Neuhaus from Berlin a few years ago that routine portal vein resection may be useful for the non-touch technique. This data and benchmark here demonstrate that, in fact, this is not the case. You have a higher mortality, no oncological benefit of doing routine portal vein resection in the surgery of perihilar, and that should not be done. And with Masato Nagino together, we just wrote now a perspective in the annals to really prevent us or indicating that we should not do anymore this routine portal vein resection, plus other comments. What's the role? Because that's the purpose of this conference on laparoscopic or robotic surgery. Probably to come today, we really have no data to look at this, but the availability of benchmark value enable now to really look at this approach laparoscopically or robotic and whether or not the results are comparable. So here we go to the gap. At the end, our mission is to go to improvements. And from the data, what we have, we can certainly think about different strategy and try to decrease, for example, this 8% mortality or 13% at 3 months, which is extremely high. So conclusion, benchmarking in liver surgery is important, is based on the best possible outcome. We can detect quality gaps in a very objective way. It offers unbiased comparable data for quality gap detection and correction of this and to have a better outcome. So the intention of this is, of course, improvement, to try to work on innovation. For example, liver transplant, is that here in terms, when we compare to the benchmark, good or not? The study has not been done in this. I finish on this consensus conference, international, that we will organize next year in June 2022, looking exactly at topic like benchmarking or what are the best endpoint to look in surgery to really evaluate the quality of our work. And I thank you so much for your attention and ready for any questions regarding this topic. Many thanks.
Well, thank you very much to the ILLS for this kind invitation to give me the opportunity to talk about machine learning and artificial intelligence in liver surgery. Basically, we're gonna start with the basics. From my point of view, I think we are now in the fourth era, or in a fourth industrial revolution. We recently had the third one in the 60s or the 70s with automated prediction, electronic computers, but now we have quickly overpassed it, and I think we are now in the fourth industrial revolution with artificial intelligence, big data, robotics, and much more to come. We should understand deep learning, neural networks, and machine learning all inside this Russian concept of artificial intelligence, which is further divided in 3 types of intelligence, of artificial intelligence. We are now in artificial narrow intelligence, which is also called weak artificial intelligence, and we have not yet arrived to artificial general intelligence, in which the robots may be capable of doing the same things as humans do, or super intelligent, which is also called strong artificial intelligence, which their capacity will overpass human one. Well, there's a timeline defined for maybe tasks that machines will perform, and it's very unlikely that very complex ones, like, for example, writing, as you see in the slide, a New York Times bestseller on talking face-to-face, it's very unlikely that they will happen even with the 6G. Maybe eventually after a 7G will be a moment in which we will walk towards a fully digital and connected world. But what is so far known, or what has been the work done in artificial intelligence and liver surgery? Well, let me start with a non-liver related manuscript which was published in Nature last year, in which more than 100 mammograms from women from UK and US were put in an artificial intelligence system, and they were compared with diagnosis of 6 expert radiologists. And as you can see in the slide, the rate of false positive and false negatives dramatically dropped in up to 10% in the US population. Meaning that definitely the interpretation of mammography, of mammograms, was much better by artificial intelligence than by ourselves. Our team has been working for more than a decade in machine learning artificial intelligence for donor-recipient matching, and after 5 papers, the last one published in PLOS ONE, we have been able to identify that, to state that artificial neural networks predict with much more accuracy the recipient outcomes and improve donor-recipient matching compared to other well-known scores as MEL, DMEL, SOFT, DRI, or bar scoring systems. This is an interesting manuscript from the Chinese team in which machine learning was used to combine with clinical features to create a radiomic profile. Let me show you. They included more than 400 patients, and in the machine, in the artificial intelligence system, semantic features, clinical pathological features, and radiomics. And I would like to remark that radiomic features included more than 3,000 radiomic characteristics per tumor were included in a machine learning database. And the authors state that they created a radiomic model to predict tumor recurrence with an individualized patient report with a risk strata for recurrence. But for me, the artificial intelligence in healthcare is linked to the big data. Let me show you that this slide is amazing. The growth of healthcare data year by year in the year 2013 was about 153 exabytes. In 2020, it's estimated to have overpassed 2,000 exabytes. Let me with a 50% increase annually on the amount of data in healthcare. This number, I just put the figure, is really amazing. I think it's really difficult for us to understand these numbers. But definitely, I think that big data in healthcare combined with artificial intelligence is going to change everything. If we are able to put all our data and combine them in an altruistic way, we will definitely change the way we are doing medicine. Let me show you a couple of papers recently published which have used big data. This one is a big data-based identification of multi-gene prognostic signature in liver cancer, and the authors just used 3 available databases, Core, MindSeq, Bio, and TCGA, and they made gene combinations, and they could identify a huge amount of genes which combined may predict poor outcomes in HCC. Dan Hashimoto in a review paper, I think he really hit it, because he said that individual patient data analysis may come to a population data analysis, and I really like this expression, and we will move to a collective surgical consciousness. And as I said, if we are capable of putting all our data in an altruistic way, we will definitely have a huge amount of big data which with artificial intelligence we will be able to work with them. This something similar has been published in head and neck surgery, in which a group of researchers have identified, have just created a multi-omic database and have collected data from 1,000 patients, and have collected clinical data, transcriptomic data, and radiomics data, and all together probably will very likely change the way that head and neck tumors are managed. Let's move to a different area. Let's move to artificial intelligence in the healthcare market. So I want to show you the repercussion of artificial intelligence now in healthcare in worldwide. I think that global artificial intelligence in healthcare market is going to change also everything. Will change preliminary diagnosis, clinical trials, dosage reduction, maybe we'll have virtual nursing assistants, robot-assisted surgery. But this figure is absolutely astonishing. You see, in the year 2019, the market was estimated to be about $4,000 million in artificial intelligence in healthcare, but probably in 7 years is very likely to overpass $100,000 million. So if you want to invest in something, maybe artificial intelligence in healthcare market is a good investment. But not only investment, but I'd like to show you this. If you go to internet, it's very funny because there are web pages talking about the war to be the first one in artificial intelligence. And if you see the number of citations between China and United States on manuscripts working on artificial intelligence is really growing up. This is the investment. This is the total artificial intelligence private investment in the last 5 years. But if you see, this year, 2020, has been the first year in which China has overpassed United States in the number of published artificial intelligence journal papers and the number of artificial intelligence journal citations. So I think this is true. There's really a war on the development of artificial intelligence in healthcare. And this is I really like this figure because we are going to talk about artificial intelligence and the pandemic. You see, in green, you had the manuscripts published on coronavirus. In red, manuscripts talking about COVID, and in blue, manuscripts talking about pandemics. As you see, when COVID pandemic was declared, this number of papers just, well, you know that it really increased. But this is funny. These are the number of manuscripts talking about artificial intelligence, machine learning, and deep learning methods. And with the pandemics, also the publication was raised exponentially. So I think that really artificial intelligence has been a great discovery as a very useful tool for the control of pandemics or related to COVID-19. Well, what's the future, or what I like to say, the near future? I'm not going to talk a lot about these two papers because I think that Patrick is going to give you a better overview. Patrick Pessoa later on is going to give you a better overview than myself. But I think that artificial intelligence is going to work together with augmented virtual reality. And these two papers have been published recently talking about the use of artificial intelligence and augmented reality for the obtainment of the critical view of safety in laparoscopic cholecystectomy. But I think this manuscript also has hit how we are going to work in liver surgery. And I think that definitely when we have a CT, we are going to go now further to 3D models, to virtual reality, to, of course, the use of ICG and the observation of the tumors and the fluorescence. Because the main aim is to do a precise hepatectomy. I think that artificial intelligence, everything that we have been talking about, artificial intelligence and big data, the main aim is to achieve a precise hepatectomy. And I really like to stop just a couple of minutes in here. It's very likely that when we have an hepatic mass, I don't think it's going to take a lot of time if we're intelligent enough, if scientific societies work together to collect big data for the purpose or for the benefit of our patients. But when we have a patient, we will very likely put that patient in a big data database, and which will be trained by artificial intelligence. And it's very likely that the system, the program, may give us a proper classification, a proper efficacy and safety assessment, and the prognosis and prediction to make a precise hepatic surgery medicine. And probably, I think we will move from this picture, which was the past in which the surgeon was the center of everything, to a future in which the surgeon will have a huge amount of data and will be assisted by machines, which by artificial intelligence tools will guide us through the best management of our patient. For example, look at this video of how some neurosurgeons are working in the spine cord. I think that it's very likely that we are moving towards this field with the assistance of virtual reality, and by having previously used artificial intelligence to find out the best treatment and the best option for our patients. Maybe this is something that worries us, is the technological singularities and hypothetical future event where computer intelligence will surpass and exceed that of human intelligence with profound consequences for society. Honestly, in that moment, it's very likely that untrained robots may turn into trained robots, but honestly, I do not really think that that's the future. I think that automation is very unlikely to be, of course not the near future. Maybe it will take a huge amount of time, but I think that human augmentation and human assistance by robot is the future. So what are my conclusions? Well, we have talked about artificial intelligence and machine learning. I really love this slide, but we have to remember that this is just two very tiny drops of the future, because we have big data, precision health, and data health with this huge amount of tools like nanobots, virtual reality, wearable device, chips, exosome, microbiome, in which we all have to work together to put them all together in big data and try to bring medicine to the next level. Because from my point of view, the clinical decision support to make a precision medicine is going to be based on advanced analytics and data aggregation, in which they will be put on advanced computation analytics and digital and electronic health data all together in big data databases. Because just remember that, think about it, that 15 years ago, it took 10 years and $2.7 billion to sequence the first genome. But now we can do that with less than $10,000 in a week. So that's quite fascinating. But we all just, and I'm gonna just finish with this slide. We just have to remember that we are humans. We have to know, we have to control the way we work with machines and not let them control us. Well, thank you very much. It's been a pleasure for me to give this talk. Thank you.
First of all, I would like to thank the scientific and organizing committee for the invitation. My conflict of interest: how could we imagine the future of the surgery? Probably more personalized, with the best analysis of the medical image and the use of an imagery surgery, more precise with new device and probably the use of robotic approach, and more predictive with the artificial intelligence. The surgery could be compared to a car trip. The first step is the planification, but it's not easy to drive by looking at the map. But it's nowadays the situation in the operative room. The second step is the simulation, and you have different software allow to have a shorter, faster, or cheaper trip. The last step is the navigation with the GPS, which proposes to you during the trip the way, and in case of errors, could in real time recalculate the way. And so we must imagine the future of surgery like this, with these three steps: planification, simulation, and navigation. Augmented reality is the fusion of a preoperative imaging and the real view to see in transparency the anatomical structure during surgery. Just one example of augmented reality for a transthoracic approach of liver resection of HCC. With the fusion, we can optimize the position of the trocar port and we would like to resect the small HCC through the diaphragm, and with the augmented reality, we can open the diaphragm just in front of the tumor. We perform ultrasound examination to be sure the position of the tumor, and with the fusion, we can see in transparency the lesion to obtain a R0 resection with 1 centimeter margin. The problem and the limit is we have 3D model with a rigid model. Respiratory movement cause significant deformation, especially for the liver. By following the superficial deformation of the body, we can obtain the intra-abdominal deformation. You can see in this view, real-time deformation of the liver. The second thing is we need automatic model tracking during the augmented reality. At the beginning of the intervention, there is a manual adjustment. Then the follow-up is done automatically. When we move the camera, when we zoom, the 3D model follow exactly the real view. And when we have the both, respiratory movement and automatic tracking, we can obtain this type of fusion. The patient's position also causes deformation of the 3D model. Just the creation of a pneumoperitoneum leads to deformation of the liver. And this deformation is not homogeneous. Little deformation of the posterior part of the liver, but a lot of deformation for the anterior face. You can see the different position of the patient, and so we can imagine the deformation of the model. So we could perform a recording at the beginning of the surgery with a RGBD camera, providing a digital mask of the surface. Each point has no coordinate in the space. And therefore, each point can be correlated to a point of the modeling and then obtain an adaptation of the model to the actual position of the patient at the beginning of the surgery, like morphing. A short video to explain augmented reality in robotic surgery for liver resection. So you can see the deformation of the liver during surgery, and so we must adapt the 3D modeling to this liver. So the first step is to obtain a 3D reconstruction with medical imaging, a CT scan on an MRI. we obtain a mesh of this 3D reconstruction, and each point have a coordinate into the space. We just recognize a small space of the liver, and with the 3D camera of the robot, we can obtain this vision. One point of the view could be correlate to one point to the mesh. So we just need at the beginning to recognize the small area, and in real time, at the beginning of the surgery, we obtain an adaptation of the 3D modeling and the view through the robot. And after, when you move the lever, the point of the lever follow the point of the mesh, and so you could obtain a real-time deformation of the lever. The difficulty appears where the deformation are very important. For example, if you cut an organ in two parts, but now it is possible to obtain a recalculation in real time, even in this extreme situation, in this example for kidney, but we can imagine the same for a right hepatectomy, for example. I show you laparoscopic video, but we can imagine the same for open surgery with glasses, and through the glasses, we can obtain a fusion of the operative view and the 3D modeling. So how we can imagine the future? I think the different solution will augment surgeon and not operate for you, but just we can imagine to obtain best surgeon with image guide surgery. I would like to thank all the engineers who have worked for many years on this subject in HERCAD and the IHU, and I look forward to seeing you at the next French Congress. Thank you very much.
Good afternoon. It's a pleasure to see all of you this morning. I'd like to discuss the 10 most cited liver papers. I'm Dr. Buell, Chief of Surgery at Mission, HCA, North Carolina, Professor of Surgery in North Carolina, Asheville. No disclosures to be had. In our discussion, the number 10 paper is the learning curve. This is done by Danielle Cherki. This study identified a constant evolution in laparoscopic liver resection. Despite a learning curve, this study demonstrated clinical outcome improvements with clinical changing after the 60th case. Operative times, blood loss, conversion rate, and length of stay have dramatically improved. This article was cited 351 times. The next paper is Laparoscopic Liver Resection of Hepatocellular Cancer by Dr. Kaneko and his group from Korea. This study evaluated the use of laparoscopic liver surgery in cancer, particularly hepatocellular. This identified small tumors less than 4 centimeters or pedunculated tumors less than 6 centimeters were acceptable. When they looked at overall survival and disease-free survival, we found that these were equivalent. There was no higher risk despite local recurrence patterns. This article was also cited 360 times. The next article is by Geller et al. This clearly looked at 31 laparoscopic liver series in a 10-year period. This found 24% of patients were undergoing minimally invasive surgery. It also found that minimally invasive surgery was safe and efficacious. This included diminishing outcomes as far as complications, morbidity, and also decreasing operative narcotics. There was no difference in oncological outcomes, so there was equivalence here. This was cited almost 370 times. The next paper is by Guyette and his group. This looked at laparoscopic liver resection early on in 1995 to 2004. In this, 113 hepatectomies were performed. 46% of these were the resections performed overall. There were about 12 conversions. There was one patient that died from liver failure. The morbidity overall for laparoscopic liver surgery in minor resections was 16%, and major resections, it was 29%. The overall 3-year survival was fairly good, with colorectal at 87% and HCC at 85%. This article was cited almost 450 times. The next article is by Wakabayashi's group, demonstrating 9,000 cases. This was more recently published and looked at 463 studies at 179 centers and representing almost 10,000 patients. 61% these were minor resections, while 18% were major only. 65% were performed for malignant disease, and the meta-analysis confirmed there was no difference in morbidity or mortality rates. This was cited nearly 500 times. The next paper is one of the more sentinel papers by Guijot. This demonstrated 11 centers that evaluated their laparoscopic versus open resection. In this group, they found that HCC had an equivalent survival at 1 year, 68 versus 80%, colorectal 89 versus 93%. The limited series did confirm the oncologic integrity of minimally invasive surgery. In particular, the ability to use a no-touch technique, an R0 technique, and a free surgical margin. This was cited nearly 600 times. Then we come to the more sentinel papers. This, the original paper by Cherki and Annals, looked at the first 40 patients performed at the Mondor Hospital between 96 and 99. This represented 19% of Cherki's overall volume. The mean tumor size was 4.5 centimeters. Laparoscopic liver resection did lead to a 6.3% conversion rate, as well as a 20% complication rate. He also noted there were no port site recurrences. This was cited nearly 750 times. Now, we come to the consensus. This is the second consensus meeting held in Morioka. This was by Dr. Wakabayashi. This utilized a different system. It used a jury system. This way evaluating different outcomes based upon morbidities and complications and margins and techniques and cost. This looked at our data to the point in a very valid way. This looked at how these types of evolution should occur, how we should make changes and recommendations for the future. This has been cited nearly 1,000 times. The next paper was by Geller. This was one of the original papers that looked at the overall examination of 127 articles with only 3,000 liver resections. This was an equal distribution of malignant and benign disease. The most common resection was clearly segmental at that time, left lateral at 20%, and lobar resections, right being 9% and left being 7%. The overall morbidity was approximately 11%, mortality 0.3%. The 3-year disease-free survival for HCC and overall disease-free survival were 80 and 87%. Very good outcomes. This has been cited nearly 1,200 times. And then the number one article is going back to the Louisville consensus meeting. This article was a group of individuals that were traditionally open, those laparoscopic, and early trendsetters using robotics at that time. The premise was to look not only at ablation, but resection, open, laparoscopic, and robotic, and really to evaluate what the state of the art was. and really kind of drive where we were going. And this became the basis of our overall study group and work group, and eventually ILLS. This has been cited nearly 1,500 times. So, in our past, we have had many great discussions, fellowships, collaborations, and overall success, not only for ourselves, our patients, but our society, ILLS. These articles have opened up a new field of surgery and is continuing to expand into the evolution of robotic surgery, where we hope the next consensus meeting really looks at what the future holds, what new collaborations and new surgical innovations we can provide. We look forward to the members of ILLS contributing and making a mutually bright new world. And I thank all of you, and I'm happy to see you all well since the period of COVID is coming to an end, where eventually we can all see and embrace and help one another once again. And I'm glad to see that we've all made it through and that we've taken good care of ourselves, our family members, and particularly our patients. So God bless, and it's been good to see you.